Hello, this is Dr. Mintz. I want to go over an interesting case. This is a chest radiograph. I'll let you look through the initial axial images, give you an overview of what you're going to see. So take a look at that, and that's the soft tissue window. And then we can move it to lung window. Here we are in lung apices. Moving down, now you can see an obvious abnormality in the left lung. What lobe is involved? You should be asking yourself. What segment of that lobe is involved? And now, if we look at the sagittal images, you can maybe get a little better idea that it's the left lower lobe, and you can see that it's the superior segment of the left lower lobe. But let's look at the soft tissue detail here, and you'll see that areas of it are of a very low attenuation. In fact, they're low enough that you might think that they're even fluid. Let's see what kind of attenuation value we're getting there. 20, which is probably fluid. Mean of 20 there. So it's fairly low attenuation. Certainly it's lower than true soft tissue, like the muscle, which is 48 in this case. So this is arguably a component of the abnormality that is fluid. This one is 17. So what could it be? Well, this patient has a fever, let's say, and a cough. And let's take a look now at the coronal series. And again, this accentuates even more clearly the fluid component in this abnormality with surrounding soft tissue. What could that be? Well, remember not to worry and look at it and try to figure out what is this and I can't figure it out. Look at it and realize, okay, there are two things. There's fluid and there's soft tissue attenuation. It's an abnormality in the lung, and the patient has a fever. Two things could create an appearance like this, and that would be a tumor with necrosis, and the other would be an abscess. The fact that the patient has a fever should suggest to you that this is perhaps a complex abscess. And in fact, you do see little air pockets that are probably not just aerated lung, because you can see the architecture in aerated lung like this, but unlike that, it's simply air. And so you have air, which you often see in an abscess in this area of abnormality, and it's not just aerated lung, and you have fluid, and they have a fever. So I think it's pretty clear this is probably going to be a large abscess. Very large, in fact. And if you look, you can see that it's involving at least the entire superior segment of the left lower lobe. Let's look at it from the sagittal viewpoint again. And look how extensive it is. So I would suspect this patient had a lobar pneumonia involved in the superior segment of the left lower lobe. It progressed to such an extent, could have been staphylococcal, that often will cause necrosis, that necrosis of the normal lung tissue took place, and the organisms then superinfected that necrotic tissue, and we ended up with these fluid cavities of pus, which means a very large, complex abscess involving the superior segment of the left lower lobe. And that, in fact, is what this is. Now, like with all of the cases we look at, there's always interesting anatomy to see. Here you can see the two lobes of the thyroid. Here's the right and left common carotid artery, and here you can see the two vertebral arteries. Let's look at this from the bottom up. You should be able to identify the chambers of the heart. Let's window it for the heart. What chamber is this? So if I have an arrow pointing to that on the exam, you should ask yourself, what chamber is that? Well, I happen to have my sister Barbara here. This is a ventricle, and so is this. This is the left ventricle, as a matter of fact. because it has a very thick muscular wall, and it creates compression that has to perfuse the entirety of the body. That's why you can tell that this is the left ventricle, because it has thick muscle all the way around, whereas the right ventricle does not. Does that make sense?
It does.
There you go. She's going to kill me later. So here's the thoracic aorta. We'll follow that up. And let's see, here we go. Looking in the superior mediastinum, here you can see the arch of the aorta. We follow that down, and here's the ascending aorta and the descending aorta. You should by this time feel very comfortable with the main pulmonary artery and the right and left main pulmonary arteries. And if I were to have an arrow pointing at a structure like this specific one right here, you don't see very much detail there, but just based on its location, you should be able to figure out what that is. And you might also be able to base your decision on the very high attenuation in that. And what it is the SVC, and you can tell that it's the SVC not only because of its anatomic relationship to the ascending aorta and the right main pulmonary artery, but the contrast is much denser in that vessel than in any of the other vessels, and that's because the patient was injected in their arm. Let's see which arm was probably injected. We'll follow that up. Well, you can see that the injection was on the right, in the right arm, right subclavian vein into the SVC. So it hasn't been diluted yet with unenhanced blood. That's why it's so dense there. And then as it comes into the right atrium, it's mixing with the blood from the IVC, which is not opacified. And then it goes from the right atrium to the right ventricle and out the main pulmonary artery, like that. And that's it.